So Belinda Maier, Dr. Belinda Maier, is our QNMU Strategic Midwifery Research and Policy Officer. Belinda has led an eclectic midwifery career over the last 30 years, and in the last year she has had the privilege, well, it's actually the last 2 years, the privilege to lead the Count the Babies campaign that, with the activism and strength of our midwifery members, has resulted in significant wins for Queenslanders and Queensland. We have won a chief midwife, the first in Australia. $16 million for rural and remote midwifery-led models of care. Publicly funded home birth. And postnatal maternity ward ratios. I'm going to hand you over to Belinda now. Have you got all your people? Can you just do the photo? Yep. For those that have Apple phones, and I think Samsung do it too, you can actually hold your finger down on a particular picture, highlight it as a sticker and insert it into an existing photo, so we might be able to Photoshop that in, the other person. All right, without further ado, please give Belinda another rousing welcome. This campaign could not have been done without her.
Oh, thank you. So, first of all, did that work? No. Oh, yeah, yep. So, first of all, I'd like to acknowledge the traditional custodians of the lands in which we meet today. I give respect to the traditional of the lands and waters in which we all walk, work and live, and elders past and present. For me, it's I live in Meanjin on the lands of the Yuggera and Turrbal peoples. I also extend that respect to Aboriginal and Torres Strait Islander peoples here today, in particular the women, aunties and grannies who hold the wisdom, strength and power of old age tradition and culture that is women's business. What am I doing wrong? Oh no, okay. So today I'm just going to talk about our Count the Babies campaign and how we got from the start back in 2015 to where we are now, and why that has been so successful and will make a big difference for midwives and the women and families that they care for. So I just want to give a brief history of midwifery in Australia. Just out of interest, women birthed at home until the 1920s. It wasn't until we started in hospitals. So birth in hospital is a fairly new experiment that we know is not working very well for a lot of women. So midwifery and midwives stem from very ancient times. We know that. We know that their language and their knowledge was through storytelling. Nursing emerged as an occupational group from the Crimean War. We know that about Florence Nightingale, nearly forgot her name. A formal act, this is in Australia, was passed which incorporated midwifery as a specialised branch of nursing. So up until the 1930s, midwifery kind of were their own profession and did their own thing, but they were slowly, from the end of the 1800s, submersed into nursing. So the subordinate position of midwifery in the hierarchy of healthcare was set in 1852 in law, with the establishment of midwifery training under medical supervision. And medical doctors were still the board directors until the 1970s in nursing. So medicine found an ally in nursing, already well established as a subordinate profession within medicine, and in its campaign to reduce the autonomy of midwifery practice, nursing subsumed midwifery by the 1930s, and so the midwifery board in the 1930s was abolished, and midwives now sit under, and to this day still sit under, the Nursing Act. Since the subordination, this will probably really help. We had the National Health Practitioner Regulation law change in 2009, where the profession of midwifery has now been recognised as a separate profession distinct from nursing. That is not to mean that we don't work well with nurses or that we don't have a lot that works across the professions, but they are separate professions, they always have been. So contemporary Australian midwives do not have to be nurses to become midwives and are not a subspecialty of nursing. So what we know through dual degrees and research is that a lot of times when midwives or nurses are doing the other profession as well, so whether it's a dual degree or whatever, they do tend to move into the one profession and stay there. So they don't always work across both, although rural and regional, we know that can work very differently. Midwives can have access to Medicare and PBS provider numbers. They work in increasing public and private models of care that are both collaborative and autonomous. And Queensland is leading the way with midwives with an endorsement. And we're acknowledged widely as primary health experts for antenatal, intrapartum, labour and birth, and postnatal care. So counting babies started the ball rolling back in 2015 and then 2016 with Toowoomba. Yay, Toowoomba, with their motion to look at babies being counted. And that got up and that became a part of the work plan for the QNMU. So how do we conceive of the notion that babies don't count? So in 1974, the Commonwealth Health Act determined funding around the mother and the baby, so the pricing of the care of mothers and babies, and they were considered one person. Therefore, babies were not counted. This funding model has not changed since 1974, so babies have not been counted as an individual since 1974. Midwives are allocated a number of women to care for, and babies are not included in their workload allocations. This is a funding problem, but for midwives, it's not their funding problem. Their problem is how they practice their profession safely and provide the care that they need to mothers and babies. I am talking specifically about postnatal inpatient care. So, I've gone back, it's gone forward, sorry. So one of the challenges at the beginning of this camp was to get midwives to start to articulate the numbers. Instead of saying we've got 1 to 4 or 1 to 6, you've actually got 1 to 8 and 1 to 12. So that was a big part of the start of our shift in thinking about how we talk about babies, the babies in our care. So what we did in the last couple of years, we did a snapshot of counting the workloads of babies in a point of time at handover. So we did 2 audits that were very successful. Midwives were very engaged in it. If we did it again, we would probably do it over a week, because a lot of the feedback that I got was midwives were disappointed that they weren't on shift to be able to be a part of that audit. So from the ANMF is now quite interested in doing a big picture. Sorry, I don't know what I did then. Oops. I'm not touching anything. So the ANMF is looking at doing this into the future, so that other states and territories can start counting babies, because this is the Commonwealth legislation that doesn't. And we're looking at probably doing it over a week, because we know that our members really wanted to be a part of it. Over the 2 audits, what we found was that there was a significant number of babies not being counted but were in midwifery workloads. So in a court of law or in a coroner's court, it won't matter that you were allocated 12 women and 12 babies, because we saw that. In one of our audits, we had 1 midwife, 1 registered nurse and 1 enrolled nurse for 30 women. So that midwife was professionally responsible for 60 human beings on that night shift, because the nurse and the enrolled nurse are working under her direct supervision. So that's not acceptable. That's just not okay. And you can see this it gives you an idea of the significant number. So 9+ babies per shift, 7%. So nearly a third were looking after 10 to 12 to 16 people on a shift. And we would have thought it might be different overnight, but it actually wasn't. The earlies had just as many, people on the early shifts had just as many babies in their care as people on night duty. And we know babies don't sleep at night. And I don't have the answer for that one. So looking at nursing ratios, we know that they save lives and money. So I've just got two scenarios to give you more of a feel of what it looks like. So we've got Kelly and we've got Kate. Kelly has got 1 to 4 patients. Kate's got 1 to 4 women or persons that she's providing care for, termed 1 to 4, so just counting the women. What we know, the stats show for Kate, of her women, we know from our intervention rates, 2 of those 4 women are likely to have a caesarean section, 1 is likely to have some other sort of intervention in labour and birth, and 1 will have had a normal vaginal birth, so unassisted vaginal birth. If we look at Kelly, who has, her patients have all had major abdominal surgery. They both need to do observations, medications, nutrition, output, wound care, rest, etc., and rest for therapeutic recovery from major surgery. We don't do that very well with our postnatal women at all. They can be 2 hours back on the ward after a caesarean section and be expecting to pick their baby up and provide care to their baby, which is not okay. Or you hear lots of stories of women crying because they can't reach their baby who's crying and the midwives can't get to them in time to hand the baby to them. That is a very, very common story. So for Kate, on top of what she's also got 4 little people attached to those 4 women, and she is responsible for all their care. And we know that the level of acuity due to added cares and observations needed is increasing. So we're doing lots and lots of interventions. We're not improving outcomes at all, and I've just done a paper where we look at 2009 to 2021, and our outcomes have not improved at all, but our intervention rates have skyrocketed. It's more than 1 in 3 women having a caesarean section now. We know anyone who followed the New South Wales birth trauma Senate inquiry, which was overwhelmed with the amount of submissions that they got, know that 1 in 5 women are experiencing PTSD, so post-traumatic stress disorder, which was a term devised for war veterans. And we are seeing women with these very psychological impacts, and that is not okay. So some of the things our members were telling us, please make them count. We're struggling. Every baby needs to be counted. The amount of babies that have IVs, antibiotics, blood sugars, etc. We did see in our audit that babies from 35 weeks are being sent to the ward to be cared for as though they're normal babies. And they can be normal babies, but 35-weeker has a certain type of fat layer, and once they've used that up, they can crash. And so they might be fine for the first day or 2. And so they need a lot of observation and care and making sure that they're feeding properly and that they're sucking properly, all those sort of things. So this is happening more and more. 11% babies are 35 weeks and over. 35 to 37, sorry. And yes, it's about damn time. Let's count the babies. So, how did we get to where we are now? We started in full our Count the Baby campaign about 3 years ago. So we've sort of been ticking over, and things got in the way, including COVID. We started with our little lanyard cards that most midwives have got now, which is on one side how to document for coding, and then how to document the workloads of babies, because we're not used to even acknowledging the workload of babies. So we had those to educate our staff around escalating workload issues around babies. We did develop in 2016, and then we've got a second edition in 2022 of our safe workloads in midwifery standards. And in the second edition, we also have included midwifery leadership and termination of pregnancy standards around those the safe loads in that context. We did do the 2 Count the Babies audits, which were very successful. We've been lobbying the health ministers, state and Commonwealth, so we're still banging on at the Commonwealth about changing that funding model that's 50 years old. But the state has still got a duty of care to the women in the state, and so we have to put pressure on our state government to provide the care, provide the midwives to provide the care for women, because we know that is for the best outcomes. Oh, thank you. See, I told you it wasn't me. We had a maternity roundtable with the Minister and all stakeholders, and when we get stakeholders, will be usually the College of Midwives, the QNMU, maybe one consumer, and then you'll have 7 or 8 different doctors' groups, all talking about things that they have nothing to do with. So, for example, midwifery group practice. They don't work in that model, but they get to have a big say on it. The home birth policy, They don't do home birth, but they get to have a big say in it. And that's not to pick on all doctors, because not all doctors, but it is a problem. It is a problem for the midwifery profession, the amount of influence people who do not know our work or do not work in our area have over what we can and can't do. I mean, it's just insane that I could go to one hospital and have a water birth at another hospital and not, purely because that hospital policies, you know, things like that are impacting on the human rights of women. Anyway, I won't go down that path. We had meetings with the minister's advisors, and then the one back. Thank you. The government did an announcement, so we met with them. We had the maternity roundtable, and they said, "Okay, great." They did a joint release with the AMA. And the release was more money, 42 million, more money for growing deadly families, that's great. More GPs training, great. Not one mention of midwifery or midwives in that announcement. So we weren't happy about that. I think Shannon Fentiman's a great health minister, but we wanted it in writing. We needed to get her attention, and so we started a campaign. Next slide, please. So we did a 6-week urgent midwifery escalation plan approved by the QNMU Secretary, Kate Veach at the time, to ensure that the government heard us loud and clear about the systemic failure of maternity services to include midwifery as a priority. So we started our campaign. You can't have maternity care without midwives. Now, the government weren't very happy with that. They wanted us to change the word fix, because we said we can't fix maternity care without midwives, because it was not a good look. But that 6-week plan, escalation plan, and all the delegations that we did and all the work we did really did put the pressure on the government to pay attention to what we were saying. Next slide, please. So we teamed with the College of Midwives, and we had lots and lots of submissions. We had regional campaigns, we had billboards, which were very popular. We had MP delegations, and in all, for that Count the Baby campaign, within 6 weeks, we had 69 midwifery activists named with their hands up saying we'll be an activist, and that was quite, that was really wonderful for me, who bangs on about midwives. Well, midwives can be mouthy, we know. Anyone who works with midwives, and I'm not looking at my team over there, we're not afraid to get up and say things and be mouthy and get out there. So we had a lot of midwives on board, and of course everyone's on board. All our nursing colleagues have been on board as well, because babies matter. All babies matter. We were all once a baby. We were all either having babies or no babies, or someone having babies. So it's an important consideration. We had a rally outside Parliament House, which was very successful. We had over 150 attendees. We probably had about 200, 250. And we had high-level media coverage. It went very well for us. And then we had a meeting with the Health Minister, which took place on the 23rd of August last year, which is coming up to that anniversary. So what we won following the rally was a state government commitment to $16 million, including appointing a chief midwife. So that is the first in Australia, and that is great, and that is really putting the pressure on the other states and territories, and indeed on our unions, to say, you know, midwives need to be led by midwives. Next. So these are some of the delegations that we had, and the members, our members were meeting with MPs who were very interested in the ratios and the fact that babies aren't counted. Next slide. This is some of the people at our rally with our lovely signs, and that was on our billboards as well. Lots and lots of awesome media coverage and lots of support. So we won. So we now have babies counted as an individual person in legislation. So it is legislated. That legislation has passed. Now, the Liberals didn't... the LNP were not happy with ratios, because somehow ratios are going to cause problems, which we know they don't. We know that through nursing, and we'll know that when we start getting ratios in midwifery implemented. So that's passed. The next step is the regulation. So don't get confused with what's going on at the moment, and I'll explain a little bit more in a sec. So the legislation is done, it's in law now, babies are counted as one. So that will affect our business planning frameworks, it will affect service profiles because they need to be counted, and the workload of babies need to be counted because they are there and they're visible. Doesn't necessarily mean that the funding model at the Commonwealth has changed, but in Queensland babies are counted as one. The next step is for the regulations under the Health and Hospital Board Act. Okay, so that's what we've been in discussions, lots and lots of discussions with Queensland Health, because they became fixated on it being on CSCF levels 5 and 6. And so that is being written now into regulations that babies, that ratios of a minimum ratio of 1 to 6, 6 being 6 people, 3 mothers, 3 babies, 2 mothers, 4 babies, 4 mothers, 2 babies, whatever that configuration is, but 6 people at the most that a midwife will look after, will be rolled out in levels 5s and 6s. Concurrent with that, through our negotiations with Queensland Health, there is a project officer that's been employed now who will go and do some legwork around what will this look like in 3s and 4s. Probably won't need to be much in 3s. It certainly won't be needed in places where there is no core midwifery staff, because those places are not going to have more than 1 or 2 women at a time anyway. But in the bigger places, it might make a difference. And so what the government has agreed to is to make sure that this project person looks into that, so that it will, in the next 2 to 3 years, come into level 3s and level 4s. So it will happen. I know level 4 services at the moment are hearing lots of things and are not happy, and I don't blame you at all, because that was never our intent for it to be at that. But you know, you kind of get sometimes pushed into a bit of a corner. But we are looking as well at the same time at changing the maternity addendum to the BPF. So that will include counting the babies, okay? So the workload of babies will start to be identified and acknowledged and built into the number of FTE that are needed to provide a postnatal inpatient service. So the 16 million has gone off, and it's meant to be including level 2 services, so services that don't have medical staff or theatre. And we know around the world that that's very, very safe if it's done properly with appropriate and timely referral and transfer pathways. Publicly funded home birth, and hopefully we'll get a baby in the next month, I think there's baby due. And that is rolling out quite nicely. Sunshine Coast was a good place to start it at. So this is not a trial, okay? It's an implementation of home birth. Home birth has been trialled and trialled and trialled, okay? We don't need any more trials. We don't need any research or evidence any further than what we've got. But it's starting at Sunshine Coast to sort of weed out, well, what are the things that we need to make sure we put in place as being the last state to have publicly funded home birth in Australia. There's very good resources in Sunshine Coast. They have a community that's very, very much needing access to publicly funded home birth. And I'm not saying that it's less in other places, but they've got a lot of things going on up that way. The key thing with publicly funded home birth and the current issues with private practice midwives' indemnity insurance is when people start framing risk. And so you have to meet certain risk criteria for publicly funded home birth, and they're usually pretty strict, not necessarily based on evidence. And like I said before, often by committees of people who've never even attended a home birth, make these rules up. So low-risk women, you know, 1 baby on board, coming head first, a range of different things, and then, you know, they exit that program if they develop any sort of complications. And, you know, like, that's okay for publicly funded home birth. For private practice midwives working in the home birth space, which I've done on and off over the last 35 years, a lot of the women that we care for are women who've had very traumatic births that would be considered high risk, but are going to do it with or without us. And so some of us choose to provide that care to women. So the big concern around the Commonwealth setting up the private indemnity insurance based on publicly funded models is it will become illegal for someone like me to care for, I would say, 60% of the women that I care for in my practice. And that is a real concern. And I did go off on a tangent then, but that's okay. So publicly funded home birth, and that can roll out to any other place that wants to put their hand up for it. Go for it. We'll help. We'll support you. This is a statewide commitment to publicly funded home birth. It's just that Sunshine Coast got up there first. So these are some of the things that the steps that we've gone through in getting to where we are. So the next steps is EB12, what we're going to negotiate in EB12 around wages, around models of care, other models of care to MGP, so that midwives who can't be available as often as they need to be and are required to be in an MGP model can still provide midwifery care, because all women need access to midwives, no matter where they are, no matter who they are. And so we'll definitely be looking in EB12 around some of those things. We want ratios in all maternity units. And I say where appropriate only because Roma doesn't have, just as an example, Roma doesn't have a core midwives, so obviously ratios won't work there because they have MGP midwives. We have got a commitment, and it's in writing in quite a few, in different letters that we have got from Minister Fentiman, that all levels of 3, 4, 5 and 6 will get ratios. So we have got that commitment in writing, and she said it over and over. The starting with 5 and 6 is just something that came out of their legislative group and kind of spiralled out into what it is now. But we will certainly are a part of that working group now, looking at how it will be rolled out in levels 3 and 4. We want more funding for midwifery-led models, and what we want is not just more funding, but we want accountability for it. So the 16 million that went out to wherever it went out, there's no transparency about it, and there's no accountability about it. So we don't know who got that money, what they've done with it. What models of care they've rolled out, that sort of thing has not happened. So we really, really need more accountability attached to funding for these midwifery-led models. More publicly funded home birth sites is really important. Removing barriers to midwives working to their full scope of practice. So whether that's working under the EPA or whether that's a midwife with an endorsement, so she has prescribing and diagnostic rights, we need to remove HHS-driven barriers to midwives working to their full scope of practice and being able to I went to one hospital and I was told I had to do their internal water birth package. And I said to them to be able to then become, accredited to do a water birth. I don't have to do anything to put a big fat needle into a woman's spinal fluid and pour massive drugs into it. I can do that easy. I can't get her into a warm bath unless I've ticked off the box that I'm accredited. And so when I said to this organisation, but I wrote the water birth policy in South Australia and I've done like hundreds and hundreds of water births, does that count? No. These things are just silly. They're just silly. They're disrespectful. They don't recognise the professional role of midwives, and it certainly limits women's rights to access these things that do not cause harm. And we want the funding models changed at a Commonwealth level. So we need that funding model changed to acknowledge babies, and we need the funding model changed so it stops incentivising intervention. So at the moment we get funding for what we do, what we know midwives are good at is what they don't do. Okay, so what we don't do is, those sort of interventions, keeping women safe and in a warm bath, for example. There's no costing to that. Whereas if you do things, there's costing to that, and that has to change. And Sarah, I think I said I was going to give you the heads up when I'm nearly finished, but I've got a feeling I've finished. So thank you. Does anyone have any questions? I was going to give you a...
I have a question.
Oh, sorry.
Hi.
Hey.
I've followed your work. I work at one of the big tertiary hospitals at Gold Coast. My question is, I work as a clinical midwife in the antenatal, postnatal, high-risk side. And my concern with the ratios is if it's 1 to 6 for 3 mums and 3 babies, how does it work if I've got 2 postnates and then antenates as well in the mix? We have put it to the director, but yeah, that's my concern. I might have 4 high-risk antenates and then 2 postnates with 2 babies. So how will it look if it's a mixed antenatal?
Look, it is a tricky one, and we don't have the answers for that one just yet, because, I mean, the baby's inside the mother, so they're both 1, but they're still 2.
Yep.
But at the moment, we aren't looking at counting them as 2.
Yep.
But the thing is that we have got in the BPF now is looking at the acuity of women. So if you had, say, 2 antenates, 2 postnatal women, and therefore 2 postnatal babies, so that's your 6. If one of those antenates is, she's about to have a preeclamptic fit and all this sort of stuff, well, obviously you're going to go 1-to-1 for that. Or, so you should be able to juggle those things on that professional judgment side of.
Yeah, which we often get. We're a high risk, so we often get the preeclamptics and stuff. But
It just means that everyone is counted.
Yep, perfect,
Yeah.
thank you.
Hi, Kate Dowsey, mouthy midwife from the Royal Brisbane Women's Hospital.
Next student.
And I was in a paid midwifery program, so I was very lucky to secure a scholarship, and I was also a paid student thanks to Queensland Health, Griffith University and my midwives in Toowoomba. And Liz is now our Chief Midwifery Officer. So I just wanted to, I am a nurse and I am also a midwife. I would just like to also extend on what Belinda talked about with scope of practice and how important that is for midwives and removing barriers to our practice. I studied through Griffith University, and when I graduated, I was signed off for cannulation, I was signed off for venipuncture, water births and perineal suturing. When I started working, I was told I could do none of those things. And I had a university degree saying that I could perform those procedures. And that was so diminishing that I could go on for hours about it. But I just wanted to make my nursing comrades aware of also neonatal discharge, well baby discharge we are taught to do as midwives. So we are not moving women out of beds. We have 60 beds, antenatal and postnatal, at the Royal Brisbane Women's Hospital. So we are trying to get women in and get women out, or birthing people, sorry. We're trying to get them in and we're trying to get them out, but we are constantly delayed by having to escalate, say, to a brand new junior paediatrician for a well baby check that we are fully within our scope to complete.
Yep. Yes. I hear you, Kate. I think there's 2 things to that. One is midwives do need to be able to work to their full scope of practice, but for a lot of places, if we say your job is now also to do well baby discharge, their workloads are already too heavy. So we need to get the workloads right so midwives can do all of that. And that was one of the outcomes from the ratios trial at the Gold Coast, was that they were actually able to do really good well baby checks with the mothers and the parents and families so that they could do that education component as well. So yeah, it is a huge problem. Griffith is a bit ahead of its time in that their students do come out with a lot of skills that most other unis don't have, and it is problematic when you're not allowed to do what you've actually been taught to do and you've been competent, assessed and educated to do it. And we're still battling in that space.
And just because there are 4 mothers, it doesn't mean there's going to be 4 babies. There could be 5, 6, 7 or 8 people in that shift. Most quads do go to the nursery, but not always. So you could have 4 mothers and 3 have got 1 baby each and one's got 2, 3 or 4 babies. So that increases that load. And then also we need to consider First Nations mothers who have cultural birthing practices, and then also non-English speaking people from other backgrounds who might have special cultural practices too. And we want to be able to honour that, and who better than a midwife to do that?
I agree. And look, if you've got a mother with quads, for example, that's 5 people. So that's within your ratios.
Thank you.